As always, our agenda aims to address the four purposes of an integrated care system around tackling inequalities, improving outcomes, making sure that we're using resources effectively, and also our broader contribution to economic and social development. Now, we've got a few new faces around the table today, particularly it's the beginning of holiday season, so we have a few people away having a well-earned rest, and we've got some colleagues deputising today. So particularly for people around the table, as well as anyone watching online, I just want to go around and do some introductions. And Rob, to you first.
Hello, my name. Good afternoon, I'm Jonathan Webb, Director of Finance at West Yorkshire ICB.
Good afternoon, everyone. I'm Majid Hussain, one of the non-exec members.
Hello, I'm Anthony Keeley. I'm the NHS England Locality Director for West Yorkshire.
Good afternoon, everybody. My name's Penny Woodhead. I'm the Director of Nursing and Quality across Calderdale, Kirklees and Wakefield, and I'm here deputising for Carol McKenna, Kirklees Accountable Officer today.
Hi everyone, my name is James Thomas. I'm the Medical Director for the West Yorkshire Integrated Care Board.
Hi everyone, I'm Kim Shuttler and I'm the VCSE Lead on the Integrated Care Board.
Good afternoon everyone, I'm Kate Sims. I'm the Director of People for the West Yorkshire ICB.
Good afternoon, I'm Harris Sultan. I'm on the Next Director scheme on the West Yorkshire Integrated Care Board.
Good afternoon everyone, I'm Rob Aitchison, Deputy Chief Executive at Calderdale and Huddersfield Foundation Trust, and I'm here today for Karen Jackson, deputising as the lead for the West Yorkshire Community Collaborative.
Hi, I'm Thea Stein, Chief Executive of Leeds Community Healthcare Trust, and I'm here for the conversation on community services.
Diane McKerricker, I'm Chair at Locala Health and Wellbeing. I'm here for the similar conversation on community services.
Hi everyone, Lucy Cole. I'm the Director of the West Yorkshire Association of Acute Trusts and I'm deputising for Brendan Brown, who represents the acute sector.
Hi everyone, I'm Melanie Brown, Director of System Reform and Integration at Wakefield Place, and I'm deputising today for Joe Webster, Place Accountable Officer for Wakefield.
Hello, Sarah Munro. I'm Chief Executive Lead in York Partnership Trust and I'm the Sector Lead for Mental Health, Learning Disability and Autism.
Good afternoon, my name is Fatima Khan-Shan. I'm the West Yorkshire Inclusivity Champion.
Good afternoon, my name is Beverly Geary. I'm Director of Nursing for West Yorkshire ICB.
Hi, I'm Mel Pickup. I'm Chief Executive Bradford Teaching Hospital and Accountable Officer for Bradford District and Craven Health and Care Partnership.
Hello, I'm Richard Vautry. I'm a GP in Leeds and I'm the Primary Care Representative on the board.
Good afternoon, I'm Becky Malby and I'm the Non-Executive Member.
Good afternoon, I'm Robin Tadnam. I'm the Place Accountable Lead for Calderdale and Chief Executive of Calderdale Council.
Good afternoon, I'm Esther Ashman, Associate Director of Strategy with the West Yorkshire Integrated Care Board, deputising for Ian Holmes, the Director of Strategy.
Hi, I'm Stacey Fleming, I'm Governance Manager and I'll be taking the minutes of today's meeting.
Good afternoon, I'm Laura Ellis, I'm Director of Corporate Affairs for West Yorkshire ICB. Thank you very much, everyone. What we have found out since we last met is many hundreds of people watch these meetings, so it's really helpful for anyone watching live or on record afterwards to know who you are. And also, I'm really pleased all the microphones are working, so that's good. Thank you very much. For those of you that are new to the board and coming to deputise today, this is a unitary board, so you're here as a representative, an expert, an advocate, but also you're very welcome to ask questions, anything you might be curious about or anything that you might be seeking assurance on as well. So we are here to make sure that we are doing our best in terms of performance and risk management for NHS West Yorkshire and our role in our wider partnership. So we're just got some meeting business to go through with Laura. We've got a number of apologies today, which we note. Would you just go through those for us, Laura? Thank you. Yeah, I'll just run through the apologies and confirm the deputising arrangements. So we have apologies from Tim Riley, Karen Jackson and Rob Aitchison is deputising, Brendan Brown and Lucy Cole is deputising, Tom Reardon, Joe Webster and Mel Brown is deputising, Jane Maidley, Arunangsu Chatterjee, Ian Holmes and Esther Ashman is deputising, Carol McKenna and Penny Woodhead is deputising, Rachel Spencer-Henshaw, Councillor Tim Swift and Hannah Davis, and Sarah Munro is going to be leaving us a little bit early at 4 o'clock. Thank you.
Thank you very much.
Next item is declarations of conflicts of interest. Does anyone have any conflicts in relation to today's agenda at all? No. And as colleagues know, we have a matrix of interest online, which is about us being open and transparent as a board. I just wanted to invite Majid to share a new role that we also want to congratulate him on as well, but we'll include in the matrix as well. Majid.
Okay, thank you very much. So since the 3rd of July, I've took up the role of Director of Equality and Inclusion at Greater Manchester Integrated Care Board. So it'll be complementary to this role, and hope you get lots of work done together.
Thank you, Majid. Congratulations again. We now move on to the minutes of the last meeting. If you remember, we met together in May, particularly to look at oral health and dentistry, as well as a number of other items that day. Colleagues, do you feel that set of minutes is a fair reflection of the day? As discussion, Harris, I understand, have you got some points that you've already shared with Laura? Pardon? Oh.
I'll drop her an email afterwards.
Brilliant. Okay. I know, Harris, you had some clarification on the wording around the dental discussion. Other than that, are colleagues happy to sign off those minutes as a reflection of our discussion that day? Great. Thank you. In terms of the action log, Laura, would you just talk us through anything to highlight with the board?
Yes, not too many to go through today. So just to update you on the open actions 8 and 9, and to confirm that we are due an update at the next meeting around a review of our arrangements around making sure that people are at the heart of our decision making. So you will see that at the next meeting. And I think all the remaining actions are either not yet due or they're down as being proposed to be closed. So there was nothing further to update on unless anyone wants to pick any of those up.
Okay. Any questions on the action log? Becky?
Just briefly, Chair, on page 15, we talked last time about the impact of the cost of living crisis on patients accessing dental services, and said that there was going to be an increase in the pace of interventions for those who are most disadvantaged. Is there any update on that we would be able to receive?
Esther, thank you.
Thanks. There's actually a working group happening at the moment. I know that the local dental committee are discussing some of the options next week. They're being put together. There is some work around urgent care access sessions and additional access schemes for specific population groups is two of the targeted areas that are being worked on. So there should be an update coming to a future board around that, but that work's underway.
Thanks, Esther.
Thank you, Becky. Anything else on the action log? No. Okay. On matters arising, just for the record for our minutes, having looked at oral health and dentistry from our viewpoint as a commissioner within West Yorkshire, we then took a mirroring paper, I suppose you'd say, to our partnership board, our integrated care partnership, on the 6th of June. And I'm really pleased as we sat with colleagues from local authorities, voluntary and community and social enterprise sector, as well as NHS, we approved policy, prevention and data sharing approaches, and all that information is available online on the section on our partnership board meetings. There's also a point, Kate, I wanted just to invite you on consolidated pay. Our colleagues from Locala had a particular question around that, so I don't know if you can respond now or whether we can come back to you on that. Yes, please. Diane, would you just please share that if you want to use the microphone? Thank you.
I think what Cathy's referring to is the fact that there has been a decision taken by the government that colleagues with outside of public sector organisations will not get the pass-through funding for the non-consolidated part of the pay award. That's left a number of non-public sector organisations in quite a difficult position. At Locala, we have chosen to pay because we think it's important that our colleagues are treated equally and consistently with everyone else in the system. And what that means is that the money that has been used for that cannot be reinvested in public sector services, which is the point of being a kick. So we're really keen and doing everything we can within the sector to try and ensure that the matter is brought to government and is given some sort of sympathetic hearing. But we're really looking for the West Yorkshire ICB to do everything they can as well in terms of supporting everyone who's delivering under Agenda for Change, but not a public sector organisation.
Thank you, Diane. Kate, I don't know if you've got an initial response on whether we could follow up.
Yeah, I can. Thank you firstly for raising this. And I know, I mean, just to clarify, I certainly have met with colleagues from Locala and your HR director. We've had some really useful conversations about some of the implications of whilst you've been able to fund the pay differential. Obviously, she's highlighted to me very clearly some of the implications of that on other areas, including, you know, developments and learning. I mean, it's fair to say it is a challenge for we as a system. I think it's a challenge across the country, Cathy. Chair, it's been raised both regionally, and I'm aware, you know, colleagues have raised that the same matters nationally. I'm aware also that colleagues from the voluntary sector and others, that there's all sorts of lobbying that has been raised. It's not without its challenge. We are aware of our financial situations as a system, but also, again, that this is reflected nationally. And of course, recognise there are other groups who are also raising similar points, but both in terms of, Kim, I can see you're nodding, and also other matters in relation to non-consolidated. So I'm afraid I haven't got a sort of a successful solution here today, but we are doing, I guess, as you'd expect, what we wish. I don't know if, Jonathan, you want to come in from a finance point of view.
Thank you, Kate. That's helpful. Jonathan?
Yeah, thanks. I mean, it's an issue that we've been aware of now for a number of months. We have continued to lobby throughout this period, primarily with NHS England as our regulator. I think at the moment the message from NHS England is very much it's a matter for government. And we continue to support those conversations in the best way that we can. And that's probably all I can say at this stage from the chair.
Okay.
Thank you. Appreciate your support.
Okay. Richard?
I think it's just to add, I think this also applies particularly to general practice as well. So, you know, whereas we haven't seen any uplift above the 2.1% that was allocated as part of the 5-year package for the last 3 years. So this is a sort of a thing that's having a real material impact, you know, on many in general practice, and then the services that we can offer. So I think this is something we would really welcome the ICB, you know, taking forward as they're able to, nationally and locally. Yeah.
Thank you, Kate. If we follow up this in our September board meeting, I know lots will happen in between as well, so it'd be good to have an update then, if that's possible. Kim, did you want to come in?
So, as you can imagine, this is an issue that's replicated right across the VCSE and causes quite significant challenges in terms of workforce, because people are forced to go then and work in other sectors. I have to say, on a positive note, I know that some of the places are reflecting some of the things that we put in our 7 principles recommendations about supporting VCSE linked to the cost of living works. I know, for example, in Bradford, they have looked at uplifts of the contract, all conversations where people have been able to adjust their contract outcomes accordingly, recognising that actually people have to keep up with market rates in terms of salaries. So I think we are seeing some pockets of really positive practice in that, and really would encourage all other places to pick up those conversations with their sector as well.
Okay, thank you. Becky, and then we'll move on to the next item.
It would be really helpful to know how much money we're talking about, but I don't know. So you'd expect, I guess, if it's for non-NHS or services that reside outside core NHS, that we'd be increasing our contract value. But of course, we're also significantly under pressure ourselves across the whole. So I think it would be really helpful to know how much we're talking about, how big an issue this is, and because then you can quantify what that means for services, and then we've got something we could be more public about. I think, Rob, it'd be really helpful to talk to in your MP briefing about that, if we knew what it looked like.
Yeah, well, if I can come in, and I hope Dan doesn't mind me mentioning this, because I think it's been discussed in public forum before. The impact for Locala for 22-23 for the non-consolidated pay was £2.5 million, which is a really significant sum given the turnover of their services. I think Locala are in probably the top 20 or so VCSE organisations nationally in terms of turnover and impact, which is why Locala have been part of the lobbying alongside other social enterprises in North Eastern Yorkshire. The issue that I'm going to sort of slightly stray off point, Becky, if that's okay, but you know, as an ICB, we'd always want to behave reasonably with our through our contractual liabilities and negotiations, etc. There is no contractual liability for these things; they are outside of government's mandate, which is one of the issues that we've got at the moment that we're dealing with.
Okay. So I think that was a really helpful discussion, particularly while we had colleagues from Lacala here. It was helpful to have it raised. Thank you, Kim, also giving a perspective from the broader sector. I think, Jonathan, if we can have a discussion with our Finance, Investment and Performance Committee, maybe it's just some information or maybe it's an action taken forward, and Kate, to hear from you at the next meeting, that'd be really welcomed. Rob?
Not to prolong this too much. So I think there is... we've got to be really crystal clear about the things that we want and why. And I think where we start from, let's start with the principles that we've got, which are that things should be dealt with in organisations. And if they can't be dealt with by the organisation, it's got to be the place. It can't be the place, it's the system. If the system can't deal with it, it's national. And that's coloured by, is the issue caused by a national decision or not? And we've been quite successful in always arguing where there's been a national decision which has a local impact, there should be a national redress. And thanks to Diane and Karen and others, we've been working with Locala, Social Enterprise UK, the NHS Confederation and other representative bodies to say, look, national government has made a decision which is that they will only fund us to pay NHS organisations for the Agenda for Change uplift. Now, the specific issue for an organisation like Locala is that they mirror Agenda for Change terms and conditions and were transferred from the NHS, and therefore it feels much closer and more acute than a more general point about the differences and the differentials between social care funding and pay, BCSE funding and pay. So we need to think about what do we want to do about those things and why as part of a workforce strategy. So my plea would be let's keep pushing on the points about Locala specifically and some other local community interest companies which may be affected on this Agenda for Change point, and then let's address the broader pay points as part of the workforce plan. Otherwise we'll get things a bit muddled up.
Okay, thank you. Thank you for that discussion, which will continue and we'll go into the next board meeting and other committee discussions, and I appreciate places may want to reflect on that as well. Okay, I'm just going to get us through some other key business. We've got the minutes of the 27th of June board, which was a meeting via Teams, colleagues may remember, where we looked at annual report and counts. Do you feel, colleagues, that's a fair reflection of that discussion that day as a board? So we take those as approved. Okay, nods around the table, thank you. And then we have our urgent decision, which again is taken under our urgent decision process. Laura, do you want to just give us some highlights of that, please, just so that we can then have it noted fully for the minutes?
Yeah, of course. At the last board meeting around delegation of policies, and there was some discussion in the last meeting around where we wanted that delegation to be, but we also knew that we had a number of policies that needed approval quite quickly. So the details set out within the urgent decision notice, it sets out the names of the different policies and where they've been delegated to, and that will be kept under review by the audit committee.
Great, thank you very much. And I'm really pleased that feedback from some of you as board members back in March said, I'm not sure that this is an efficient use of board time in approving a number of policies, so this is a way of trying it out for the next 6 to 12 months or so, making sure we've still got oversight of that. Thank you. Okay, we're now going to move on to item 5, and we've received one public question from Dr. Stephen Clough, who's also here with us today. As usual, a colleague will read that out, and then we'll have a response, and then Dr. Clough, we can follow up afterwards with you in writing. Laura.
Thank you. Yes, so the questions that we've received are, my question relates to the progress of complex care in the community, and in particular the hourly rate of complex care PAs. So thank you very much for sending in the questions. Just to explain that complex care is specialist care provided to people with health or social care needs, and PAs are personal assistants who perform a variety of tasks. So our focus on discussion today is community services, and you will have seen within the report on the agenda that the board is being asked to endorse the ambition in West Yorkshire to keep people well, closer to where they live, with the need to support the shift towards care outside of hospitals and prevention. And in respect of the hourly rate of complex care PAs, as this does depend on local authority area, we are going to ask the local place team for Dr. Clough's area to respond to you on this outside of the meeting. Thank you.
Great. Thank you very much. And our colleagues in the place team are going to respond on that further as well. So thank you again for the question, and we'll, as always, put that up onto the website as well. We continue to welcome questions from members of the public through our partnership board and through this forum as well. And as always, we publish those online for openness and transparency. Okay. So we're going to move on now to item 6, which is our focus on session. Thank you, Thea and Rob and Becca and many other colleagues who are here today for joining us. As you know, each board meeting, since we have been meeting in full and in person in September last year, we have taken a topic, had a deep dive and worked out how we together as the Integrated Care Board can support colleagues working in a variety of services and places. So I want to thank everyone who has worked in this room and behind the scenes in preparing the document. It's great to see the recommendations that are coming through that are asking we as a board to support and approve, and also the examples of work that is going on across our communities as well. So I'm going to hand over to Thea and Rob to give us some opening remarks and pose some questions. And as you know, colleagues, we had an engagement session earlier, particularly hearing about patient stories, the good and not so good, which has prompted and supported this discussion also today. So Thea and Rob, over to you to introduce the topic.
Thank you, Chair. So thank you, everybody, for having us to talk to you today about community services. So I'll just do a little bit of an introduction. I'm going to take the paper as read, as I'm sure everyone's been through it. Before I start, just giving a bit of context, so obviously we'll talk about community services. We're talking about community health services here today, so I think it's just important to make that definition, and we might use various kind of shorthand for that as we go through this conversation, but there's a really helpful definition within the paper which describes the types of services we're talking about today. I think it's important to note, though, that when we're talking about community services, these are services that provide all-age care, and we already know the importance of keeping people well, supporting them to live independently in their own home or within a community setting. I think it's important to say that this workforce amounts to about 1/5 of our total NHS workforce. So I think in the previous session we had a very brief conversation around a lot of the attention and a lot of the discussion is often focused around hospital services, acute services. We know that the people delivering these services deliver a massive amount of volume and activity within people's own homes and in community. So important to draw that point out. Within West Yorkshire ICB, the functions within our 5 places, most community functions are delegated to the 5 places. This enables a joined-up planning and delivery in response to that local need, and we know across our 5 different places there are very specific different needs within those. And I think the other thing that we know, but again it's worth stating it again, is that the services that we're talking about here today provide some of the best examples of multidisciplinary and multi-organisational working, both at place and at that more kind of micro neighbourhood level. So we know that there's a really broad representation of services working together in partnership to provide some great care for people wherever they are in the community. We also know the evidence base is really strong. So as much as we're trying to make a kind of greater investment within these community services, we know there's a really strong evidence base for doing that. So a recent Edge UK report indicated more than 850,000 hospital admissions a year in over 65s could have been avoided with better community care. We're starting to see, I think, particularly in recent years, some real great examples of where we're starting to turn the tide on this, particularly with the urgent community response and the virtual ward services in most recent years. But for that optimism, we also know that the challenges faced within community are really complex. Whilst they mirror many of those that we're seeing within different sectors at the moment, we know they relate to finance, increased demand, complexity and acuity, as well as an ageing population. So we've definitely seen post-COVID, during the recovery period, a more typically complex and acutely unwell patient that's been managed within the community. So on one hand, that's a very positive thing, but again, I think we need to reflect the challenges that brings for teams in managing that really complex workload. We know that recruitment and retention challenges are also very challenging for the teams at the moment. But again, I think some of the indications within the NHS long-term plan are positive, with as much emphasis on retention of people as much as retaining them within and recruiting them in the first place. And we know across West Yorkshire, as much as we have a level of standardisation, we have lots of variation, some of that very positive, lots of innovation within our services. But I'll come on to talk in a moment just around the provider collaborative that we've established in recent years and in recent times have strengthened and is trying to take further. There's a real opportunity within that work to look at those variations and look at the different ways in which we can support a kind of standardised offer wherever appropriate. So just a few words around the provider collaborative. So we, in similar to our mental health collaborative and our West Yorkshire Association of Acute Trust, the collaborative meets monthly There is executive oversight within that group, and I think we've identified 2 or 3 key priorities in the first instance, which are listed in the paper. We've made a commitment around coming to a common set of metrics that we can use to establish the kind of efficiency, the quality of the services that we provide. We've committed to working together on staff pay, portability and skills of teams. And we've also committed to work together on our digital systems around how we can get the basics right to move towards kind of more exciting place in the future. I'm not going to draw out the kind of recommendations in detail, but I think it's just worth kind of referencing the 9 recommendations that are made to the board today, and a number of additional points around the things that we view coming out of the collaborative as the kind of opportunities where we can work together in future. I think there's the things that you would expect to see in there with reference to the fuller report, which across all 5 of our places we see as a really key kind of mechanism for change and continuing to develop services, as well as the role of community services in reducing inequalities in our population. I'll take a pause there, and if it's okay, I'll just ask Thea for any reflections before we open up for conversation.
Thank you. As you said, I would really like to thank Becca, who has joined the collaborative and has been the person who has created this paper and the clarity around this. As we all know, working with lots of people who've got lots of good ideas and then creating one paper out of it is a skill. So we're very thankful for Becca for bearing with us during that time. I think the overall framing I would like to give, and maybe I will be too bold to make this statement, is I don't think there's anything very controversial in this paper. I would hope and imagine that there isn't. I think the controversial issue that I would invite the board to reflect on is why hasn't it happened in the country as a whole for so long? And what is really holding us back? There are many, many real things holding us back. And what could this board do to try and unlock those things? So as I said, I make a bold assumption that there's very little in this paper that is controversial. But I think the controversy lies in its implementation. Thank you.
Thank you very much. That's again, thank you for your time. Thank you for the preparations. Thank you, Becca, as well, and there are a number of colleagues here still joining us for the meeting and in the engagement session. As you know, board colleagues, today we met people working within Calderdale and Huddersfield Foundation Trust, Yorkshire Ambulance Service, Locala, and Bradford District Care Trust as well, sharing with us a variety of services across children and young people services, urgent and emergency care and community dental as well. So board colleagues, I'm really grateful to you for listening, taking on board the stories, the learning and the challenge which Thea has reiterated here from the earlier engagement session. So we all are committed to care closer to home. We're all committed to working in neighbourhoods. I wondered if there's anyone who wanted to start the discussion today, particularly, first of all, if there are any points for clarification, but also what more can we do? And here's about being curious as well as seeking assurance and making change. So I don't know who'd like to go first. Looking around the table, Richard, and then Mel, then Fatima. Thank you.
Thank you for the paper very much and for the discussions before this board meeting. As a GP, I see the benefits of community services on a day-by-day basis and can really value the support that takes place in many people's homes around the community. And I think the point you made earlier, that the vast majority of care takes place within the community, and yet we don't give it the priority that we really need to. I was particularly wanted to draw attention to the second and the third of the recommendations within the paper that we're encouraged to endorse, and which I do, which is about the recognition that for our NHS services and indeed care services as a whole to be sustainable in the future, we do need more care to take place within the community and less care to take place in hospital settings. But for that to happen, we need the resources to be there to make that happen. And that might make difficult decisions for this organisation, as other organisations, not only as we shift the work, but as we shift the resource and the focus to support that activity to ensure that the workforce is there and supported to be able to deliver those services. In the discussion we've just had, just this moment, about the priority given to NHS trusts and the funding for a rightful uplift in pay for NHS workers, that hasn't been recognised in many of our community and voluntary sectors who depend on that pay to be able to carry on doing what they're doing in the dedicated way that they do. So I think it's essential that we link the two together. Not only do we see the capacity within community services to potentially do more if the workforce is there, but we do need the resources there to make that sustainable, and that applies right across community and primary care services.
Great. Thank you so much, Richard. We'll take a couple more comments, Mel, then Fatima, and then maybe Thea and Rob, we can come back to you, and then we'll take another grouping as well. The theme of money, I think, is going to continue, so let's keep talking about that. Mel, to you.
Thank you, Chair. I'm really supportive of all the 10 recommendations in the paper, and Richard's already picked up on a couple of the things I wanted to say. But what I'm curious about is if we were speaking to our community workforce, what would be the top 2 things they'd ask us to change that would make a real difference to their working lives at the moment? And my guess would be, may not be money, but is there something else that we can be doing to support our community workforce?
Thanks, Mel. And we'll hear from Fatima, and then we'll go back over to Thea and Rob. Fatima.
So I'm never one to resist a challenge from the legendary Thea Stein. Unsurprisingly, I've got no issue with the recommendations, but I am particularly interested in the latter point of why has this not happened before? And I think there are a variety of reasons why, and I think culture is one of them. Cultural competence, but also organisational culture. So if we're truly to make this a reality, that will require us to work differently, and people are used to working in a certain way for a reason, and people sometimes struggle with change. So I'm particularly interested in how we resolve that through OD, but also demonstrating the art of the possible. And we've seen the art of the possible in the engagement sessions this morning, because we need to give resources and power to, say, the VCSE sector, to unpaid carers, to social prescribing link workers that have worked in these communities for quite a long time. But when I've worked with them as a personalised care lead, I've been told that they really struggle to make an impact because of some of those organisational cultural barriers. And we need to be honest and have that honest conversation if we're going to make this work. I think the other thing that's really important to recognise is that people's success in this depends on their ability to navigate complexity. And if you're somebody that is experiencing deprivation, you're a certain age or a certain heritage, there are more perpetual barriers that you will need to encounter. So how do we, if we're truly going to be innovative, address some of those barriers? Because that will require us to think really radically about who we're trying to support and how we do it. And I suppose my final point is recognising, and we talked about this downstairs this morning, a group of individuals that aren't quite recognised within the paper, which are unpaid carers like me, and sort of recognising that actually we are key enablers of this workforce. We did talk about care coordination and the importance of those roles, but actually carers do that already, but they really struggle with being recognised as experts in care and also developed to contribute to this, as does personalisation. So my challenge, and there is a challenge, is if we're really going to make this work, how do we invest in those 2 particular areas? Because without them, we won't succeed. And then my final point is an opportunity, I think, which is, as a carer, I've had many home care organisations in and out of my house. I've had many conversations with them about their skills and expertise, and they're really phenomenal people. But they struggle with navigating and being able to succeed in those vocations because of some of the structural inequalities that are in different parts of the system. So from an integrated care perspective, what is our influence to support the private care sector, and also working with our colleagues in local government to support some of those areas, because they're instrumental in our success too.
Thank you very much. Thea and Rob, you may not have all the answers, but what are your reflections as well? There's something there particularly about OD and culture, the role of carers, personalisation, the equity in the workforce.
Yeah, we're agreeing which order we're going, and then we'll go the other way.
Great.
I will go the other way. So Fatima, I think all the points you make are really, really well made, and I can only use examples from Leeds of ways in which we've tried to do that. So in Leeds, we have commissioned £1 million into third sector organisations through a service we call Enhance, which is what is then integrating those third sector organisations with our neighbourhood teams to work alongside them to be partners in care in a wide range of ways. We also have developed a role called self-care facilitators who work particularly to support people to care for themselves. And we've been rolling that model out with Lucala recently and with other places across West Yorkshire, because we can demonstrate, because the currency is always acute bed days, we can demonstrate how many acute bed days or how many visits we save
because of self-care facilitators. And on home care, and certainly Rob will be aware that myself and the Director of Social Services, previous Director of Social Services and Leeds, have been doing some work to commission home care agencies to again be able to work as an integrated part of neighbourhood teams, especially where they're on 0-hour contracts and they can pick up extra hours to work in a different way within it. So I think there's lots of interesting models, and because of the collaborative we can come together and we can share, because I can tell my stories, but every community service has their own interesting place. Mel asked, what would my staff say? What would they want? They'd say the same as acute services staff, which would be, could we have more staff, please? We'd really, really like more staff, and we'd like them yesterday, and we'd like them today. And they'd also say, from a community point of view, we'd really like to be respected. We'd really like to be respected in the same way as if you're a hospital nurse, you feel respected. And that people understand that isn't actually all call the midwife out here. It's actually a lot more complicated. There's still a huge amount of misapprehension about the complexity of care that goes on in the community, and that, you know, it's intravenous drips, it's very complex care, it's bedside, analytics. There's a whole range of care, both for children and adults. And if you're looking at, Rob mentioned before the break, that a rise in end-of-life care. During COVID, we saw a 40% rise in people dying at home, and we've seen that sustained now. I don't think we've seen the investment, but what we've seen is our services dealing with very complex end-of-life care day in and day out. So I think they'd ask for more workforce and more respect, but I'm not sure what Rob would say for yours.
Yeah, I think certainly from first-hand experience, I think the thing we need to reflect on with the community is kind of the impact of cost of living. So if you speak to teams in recent years or recent months, even the kind of increase in fuel, some of I think the understanding of the difference in the role between other sectors that we work with, these people working in the community, there's definitely an impact that it's different for them. And so whilst, for example, staying on the fuel example, prices have come down recently, there are still people who really are feeling the kind of the pinch there, driving, during the day for their work. So that's definitely a key bit. But I think that the second point I was just going to make was about representation. So how we represent and talk about community services is really important. And, I think we made the point previously around, Thea just talked about bed days. I think it's really important that we talk about it in a language that teams would recognise. So those waiting lists within community that probably get slightly less focus, equally as important. So people who are waiting on kind of physiotherapy waiting list, even from an economical perspective, before you get to the quality and the patient experience, it's really, really important that we have that focus, and the kind of that parity between acute and kind of community is there. So I think those are probably the main kind of two bits to pull out, Chair, on that one.
Great, thank you. We're going to go to our next set of comments and questions. Kim, I've noted there. So if we go to Becky, Majid, then Kate.
Thanks.
Becky.
Thanks so much, Rob. Thea, this is one of the best papers we've had in terms of really meeting, really trying to charge us with some difficult questions. And I'm sort of concerned that we'll end up just talking about it rather than making any decisions about it. So I'm unclear of the process we need to be through now. So one of my questions to you, I've got a few. One of my questions to you is, you talk about you want to be considered as an equal partner. What do you need from us for you to be considered as an equal partner? So that's the first one. Come back to it because I've got a few other things. The second one is, I guess, is back to the issue of really how do we start taking a needs-based rather than demand-based approach to our work. So, who shouts loudest gets. Our flat offer in primary care means that those who are used to getting more in primary care carry on getting more, and those who don't carry on getting less. So flat offers are not the answer. It is about personalisation. It was so good to hear that question earlier on from the public. So if we're going to try and take a needs-based approach, that means we've got to rethink our models of data collection and knowing what's going on. And then we have to build out our funding models from need. And that's a longer-term approach, but we need to start. So I know in Leeds, when I was talking to them yesterday, they have a segmented model. It's what has children, then it has frailty. And the questions are difficult, and they are difficult. But I still don't think that's clear enough yet about what our needs are. So what do we think is going on, and what do we think is going on now and into the future? What can we do as an ICB around business intelligence to ask some of those questions, both in place and across the ICB? So let's find out what the real issues are and not build out a fantasy. Let's take the opportunity of neighbourhood teams. Integrated neighbourhoods are sort of newish, something. PCNs plus, whatever. But we can start with need from those, not assumptions. If we start with assumptions, we're going to have loads more frailty care, and it'll forget our children and young people. And we know there's a huge demand around children and young people. It says here 25% increase in waiting for children and young people nationally for your services, for community services. So we have got to say, actually, it's not just all about old people. The stories this morning were fantastic. We have to move our lens here. And so it's not something we keep saying, and children and young people, but they're core. Rather, we keep saying, plus don't forget, plus don't forget. A bit like you were saying, don't forget community services. Now we're saying, don't forget children and young people. Rather than, they're just part of our need. And so they need to be whole. So that's the second thing. Third thing was about policy, Rob, I guess, which is, you're talking about what needs to be done nationally. I don't know if we're clear enough about the impact of poverty on our services. We've got quite a nice poverty strategy, but I don't think it's quantified. So how much difficulty is poverty causing us and causing our families and causing people? How much ill health is it generating? How much would it be better if people had more in their pockets versus us trying to wrap around and pick up and, in effect, medicalise poverty? So I'd want us to quantify that more and be clearer to the public and to our MPs and to others. That's the third one. The fourth one around policy is educating the public about what care is. So changing our language. You talked in the session before the public sessions here about, we talk about these as out of hospitals, if hospitals are the only thing that matters. We know in our places we don't behave like that here in West Yorkshire, but we have got to do some work with particularly with our MPs, particularly as we're coming into an election time with all our parties, about where's the need, where does it reside, and where we need to be paying attention to. And that also includes our communities. I know Karen is our most fabulous media and comms person in the whole of the country. I think she's brilliant. But actually, how do we help communities understand that the stuff that they're dealing with themselves in their homes is as important as the stuff that goes on in hospitals, and we care about that? That's the fourth thing. And then I guess the last thing, I suppose, is NHS Assembly, 75 years, it really said that NHS England has to address its finance model to ensure that primary care and community services are funded to meet needs. So this is not just what we're going to do, but it's an ask, Anthony, to NHS England. How are you responding to those very few points from the 75-year National Assembly report and from this ICB, because we ask about it frequently, which is how do we get that sort of change in funding and a lens to the funding so that our private practices work in poorer communities and our overall communities are getting better. And the last thing is that you've asked here, Thea and Rob, about the issue of commissioning inconsistencies. I just wonder whether we could take that to the Transformation Board, because our job there is inconsistencies in commissioning. So I think as a chair of that, I would volunteer to take that as a piece of work, because I don't know who else will, but if anybody else wants to put a hand up for something to do, but I'm offering to do that bit.
Becky, thank you very much. Before I go on to other comments and questions, so I've made notes as we go along, so I think perhaps later we'll, as usual, come to Rob later on for comments and reflections. I know you were very much involved with NHS at 75. We'll invite Anthony later from an NHS England perspective. But just on those points, Rob and Thea, around what do we need to do to enable community services to be an equal partner, how do we take that needs-based approach, business intelligence, we've talked about that before as a board. The policy, I think there's something that you've talked about, Becky, on poverty that I think we can work with Esther and Ian on in taking more broadly to the partnership board and working with local government colleagues and educating the public and MPs, I think is a thread that's come from other meetings that we need to continue with. So Rob and Thea, if there are any immediate thoughts there, and then we'll go to other colleagues who are waiting. We've got Majid, Kate, Mel P and then Kim.
Thank you. Thanks, Becky, for those questions. I'm going to cheat a bit and make a few general points, which hopefully kind of covers the kind of essence of what you're saying. I think what the kind of the ICB has done, and within those places as well, is given us the kind of the endorsement as a collaborative. So I think the relationships we've now got and the benefit we're having of Becca's role, kind of bringing us all together and facilitating us, is that you've given us the space to do some of this work. And so we've still got lots to do, but I think using the kind of the fuller report and the neighbourhood working as the basis of this and building on the things that Richard's described, we know what good looks like on this. It's about those teams working as closely as they can in those populations of 50,000. Your point around the population health element of it, I think those teams who are delivering those services know their services and their kind of their need in their population the best. What we need to do now is support them with the tools that they need to do that. So we've got some great examples within the collaborative of where we're picking out that highest need, where we're stratifying our caseloads and where we're targeting those people who'd most benefit from that care. they're not always those traditional people who would rock up in A&E and kind of need that acute care. So I think there's lots of optimism there on that, but I think that the key point in response to what you're saying is the benefit of the skills, particularly when we're talking about things like inequalities and deprivation, it comes from those people who are going into those areas, into people's own homes, and are understanding the challenges that they're facing. So whatever we do as we head towards this next 12, 18 months, 2 years, is build on that knowledge, because it's pointless us sitting around pretending we know the answers when our teams can help inform the work and can help us.
I'll just make 2 points. One of the things about being treated as an equal partner is about understanding the way national policy hits. All our waiting lists are outside waiting list initiatives. We have no access to any money for any of the waiting lists and community services. So if you want to understand the way the national debate therefore shapes the way community services are experienced, that is really practical. And they are huge waiting lists that have massive impact on our primary care colleagues in particular as a partner, and also, of course, those families and those individuals who are waiting. The second partner I think is really important, isn't actually round this table unless I don't understand who's exactly around the table, so forgive me, is universities. The way people are trained in universities, and we're going to, I'm sure at some point this board will consider the long-term workforce plan, and the way in which still on some courses, some of the time people are told the first place you have to go is an acute hospital. Go to the wards first, etc., for many, many jobs is really important. So working in partnership with universities around parity for community and extolling community is going to be absolutely essential if we're going to also reach the targets in the long-term workforce plan.
Great, thank you. I am going to use chair's privilege because I know Harris wanted to talk about that as well. So if Harris and Kate, you want to respond to that, and then we will get back to our waiting list of going to Majid, then Mel P, then Kim. So Harris, this is something you wanted to talk about on placements.
Because at the deep dive on workforce in January, we did touch on the number of placement students in hospital versus community. I think it was 85% of placements were hospital-based. And as a medical student myself, I've not got a single placement in community-based care, and I'm never going to see it till possibly my foundation allocations. Talking to someone from Locala this morning, told me that they've recently hired a nurse that was straight out of uni, which isn't typically done because it's recommended to have some hospital experience before they go into the community. So I've got a question on what work is currently going on, working with educational institutes and medical deaneries to help shift the dial on the allocation of placements only being in hospitals, because we've had the conversation here before, and also what more collectively can we do as an ICB to lobby that and shift the dial?
Great, thank you. I could recognise that Harris, you're in of a similar mind to Thea, so it was good to connect the two things. Kate, you're next on the list of commenting. Do you want to come in next?
No, I will, thank you. And the reason I'd put my hand up, firstly, thank you all for the paper, and Rob, I really welcome the fact you've obviously included the long-term workforce plan in this. I think there is some opportunity within the long-term workforce plan. As Thea said, I'm sure we'll get into some real detailed discussions on that on its own. If my own team were here and I was saying to them what is the priority they believe around the long-term workforce plan, the first two words they would say is community placement. So similar to the point Harris made back in January, as you said, we kind of highlighted the number of placements that are currently not in communities. I think the work that is really starting to happen is to identify that capacity. And I was in a regional national meeting the other day about the long-term workforce plan, and it is all about how do we increase the number of placement opportunities out in communities so that many of our students of a number of healthcare professions obviously have that opportunity to experience it very, very quickly in their sort of their time of studies. So firstly, I welcome the fact you've referenced that. I see one of your recommendations, number 4, is absolutely about the community workforce being a priority of the West Yorkshire People Plan. Again, I think if my team were here, they'd absolutely agree. They think that's got to be one of the priorities. Talked about community placements. I was really pleased this morning to hear about some of the active work around, just feels like new ways of working, different groups coming together and finding that solution. And again, I think there's far more work that we can do on that particular piece. Again, the workforce plan references retention. I agree entirely with what you said, Rob, that if we don't keep an eye on that, then it will all be, a significant uphill challenge. And I think the retention agenda for West Yorkshire, we've had the first sort of review of what does the priorities around retention look like. I think this work is very timely. And then just my last thing, Chair, is obviously I meet quite regularly with Becca and with Diane. And at our very last meeting, only a couple of weeks ago, we talked about doing some, I think the word needs analysis around from a workforce point of view. What are the community services workforce priorities that we in West Yorkshire can support? So I know we're going to pick that conversation up in the next couple of weeks to really take that agenda forward. But certainly welcome the paper and that particular recommendation. Thank you.
Great. Thanks, Kate. I'm going to go now to the next group. We've got Majid, then Mel P, then Kim. Majid, you've been waiting patiently.
Nice, okay. Thank you very much for the paper and really welcome the content, and really good to see the focus on multidisciplinary teams working right at that neighbourhood level. I think that's not coming through strong enough, and I know there's been some reference to it within the paper, is the focus on reducing health inequalities and variations. So even when you look at 6.6 and the priorities of the collaboratives, it talks about metrics, it talks about staff, it talks about digital systems, but we really need to get to the heart of those inequalities, whether that's access, experience and outcomes. And there is a danger if we don't say it, and if you don't say it strong enough, that it's not going to happen. And when we look at the recommendations, equally we recognise some of the challenges, but we're not recognising inequalities, variations enough. So I think there is a risk of that work getting lost a little bit. So we really, really want to see a stronger emphasis of that in this work going forward. Thank you.
Thank you, Majid. I know you're very passionate about that. Over to Mel.
Thank you very much. Thank you, guys. I think particularly around recommendation 8.3 and the construction of a case for change to commit, I've got a question around where you think that case for change should sit, whether or not it sits at West Yorkshire level, because I think the paper would imply that, or whether it sits at place level, because my belief is that whilst there is something to be escalated upwards to influence policy, for sure, around language and the prioritisation on ring-fence monies or whatever, where the rubber hits the road on all of this stuff is in the places. So you won't see Bradford Teaching Hospital on your list of community providers, and yet we do provide community services and services out to our community. And that's a conscious decision on our part to say, well, we don't need to sit in this because our partners sit in this, Airedale sits in this, Care Trust sits in this. And increasingly our interactions are becoming much closer. So I can tell you at my board in the Acute Trust last week, we had colleagues from the Care Trust talking about the very example that sits within the paper. And the language may not be the right language when we talk about virtual wards, because that implies a hospitalised model. It might not be the right thing to say a virtual hospital, which is the way that we talk about some of this stuff. But on the other hand, it might be a helpful way of weaning the public off the expectation that the most superior care is delivered in a hospital, because that's not true. We absolutely know that's not true, and yet there is an expectation set in the minds of the public that is. You will hear people say, I've heard them say, I must be really ill because I've been referred to the hospital. So I think there is a conversation with the public as much as anything else influencing policy upwards and out in our places to say this is not just as good care, this is better care, because you don't then carry the inherent risks, which all of us appreciate if we've lived and breathed hospitals for a long time, are there in hospitals, the deconditioning for patients, the infection risks, all of those things. So I think it's really important when Thea talks about the desire to have a level of respect for what happens in the community. That happens in practice, I think, best, not because we make a stand to talk about it in that way. When colleagues from one sector start to work across the boundaries so that you can't see the joins. And that virtual ward conversation, virtual hospital conversation, illustrated that fantastically. Because what you get then is not just a respect for what colleagues do, it turns into an appreciation and an admiration, actually, because all of that becomes much more visible at the points at which we kind of interface. So for me, it's that integration piece as much as it is recognising the value of a particular sector. I think that's really important. Yeah.
Thank you, Mel. That's really helpful. And as we're going to go to Kim next, but if there are any other place leads around the table who want to share their reflections as well, it is that discussion at place level on the integration, isn't it? Thank you. And I know, Thea, you shared in the engagement session earlier how the patient satisfaction was higher when people were receiving their care at home, particularly via the virtual ward model. So we've had a theme of tackling inequalities and access, and that public conversation and valuing care in the home. And we also in our engagement session earlier talked about the risk that is taken as well, that clinical risk that we recognise that is taken in care closer to home as well. We're just going to go to Kim now, and then Thea and Rob will come back to you. Kim.
Thank you. So I'm also the SRO for what's now called Power of Communities, because we've agreed to ditch the harnessing bit, because I think, yes, harnessing as a term isn't very useful, and it brings me onto the point, I suppose, is as an integrated care board, it would be lovely to have some conversations that weren't specifically just about services. So it's really helpful, I think, this paper to understand more from my perspective about community services. We've had other sessions where we've talked about people-powered NHS, how we really build on the assets in community, move the power to communities. So how might we have the conversation where we're bringing together the conversations about evolving community services with the stuff about how we're, what's going on with, in local government, where might public health be in this conversation? So we've got a true vision for what our healthy communities work looks like, what health creation in communities look like, and how we're actually shifting the power to people, because that's in our vision, isn't it? That the principles of subsidiarity, we're starting with the person. We heard really powerfully this morning about that, I think, about families where people live and the determinants of health. So I guess I would love as a second stage to create an opportunity for more conversations about bringing together the conversation about services with some of the wider community conversation. I think that really ties in with Majid's point and a couple of other people's points, Becky's points. And then I suppose the final question I would ask is if we ask communities what would they like to see, if they had a magic wand, if they had the blank check about transformation of support and care in communities, what would their answer be? Would it be more, it may be more community nurses, etc., or it may not be. So that would be interesting to explore as well.
Thank you, Kim. That's great. And that links as well your point also on local government, that there has been the launch of the West Yorkshire Plan through the combined authority with our 5 local authorities. And one of their aims is around healthy places as well. So we're all moving in the same direction. So there are lots of policies going on, and now it's about making the reality, which goes back to Thea's point. So Thea and Rob, you've got a few things there around healthy communities, connecting things together better, working with the public and tackling inequalities. Are there any reflections there? And then we'll go to Esther, then James.
Yeah, I'm going to start. We're sort of taking turns. So completely take the point, tackling inequalities. I think sometimes we just assume it's there, but we should always say it's there, and we should have said it more strongly. So point well made. Conversations with the public, I agree with you, Mel, and if you look at some of the countries in the world that have done this really well, like the Netherlands, it took years to have proper conversations with the public over a period of time before they could then embed the changes that they needed. So again, I think absolutely right. In terms of West Yorkshire or local, I would agree with you. I'm a place-based person, and I think these are the conversations that take place at place. However, I do think there are statements or pieces of research or pieces of thinking that can be situated at West Yorkshire that says these are the things we know, so everybody doesn't have to rediscover them. These are the things we know. These are the facts. These are what good looks like. But you will do it in your own ways locally, but let's not have to rediscover certain things. So maybe there's a challenge there at West Yorkshire. I think what colleague Kim said there is absolutely the right way of bringing people together. We call them local care partnerships in Leeds, which is a wider partnership. I know Bradford have very similar models, and so do other places, to try and bring all partners together to work together in an integrated way. I'm a great fan of Hilary Cotton's work, Radical Help. If you want to look at a model of what the public want, I run the local care partnership team in Leeds. I give everybody a copy of it when they join to say, this is the model for the future. If you've not read it, I think that's the way in which the people have told us, and Hilary writes really well around what a radical model is for the future.
I'll just add briefly just to Mel's point, if you don't mind. So I think absolutely agree with Thea around the place bit. I think if we pick on a couple of things that have worked well in recent times, it feels like the UCR, I'm sure there's still more work we need to do around urgent community response and virtual ward, but feel like a bit of a success story, and I suppose it's just challenging ourselves around why they are, and I think it's because it had a bit of dedicated resource that was kind of, you know, had something around it that said you've got to do this, and we all understood it in really simple terms. So as much as I think I drive some of my team mad sometimes when I'm saying it needs to be simple enough that we can communicate. The real work will happen in the team, but we need to be able to get the real message across around the impact we're having and what the model is. I think those two things pass that test. So I think as we head forwards, we need to try and kind of apply that test wherever possible, because when it gets into that place conversation and when it's happening 5 times, we can make sure people are supportive and they understand the kind of the effect and the change that we're trying to have. So yeah, just call out those 2 examples. Thank you.
That's great. And I think as this conversation's continuing and reflections for the engagement session is perhaps how our place leads and working with place committees can take this report and take it into their discussions over the summer and into the autumn as well. I think it's your reflections, Mel, as well as your challenge as well that comes from that. Okay, so we've got some other contributors now. We've got Esther, then James, then Sarah, then Lucy. And then we're going to probably run out of time, but I love these sessions. Great. Esther, to you.
Thanks, Chair. And I just want to build a little bit on something that Becky was talking about in terms of future demographics, what the need's going to be in the future, and bringing it back to strategy and planning, which might seem really dry, but actually this is what brings it alive, this work. And I'm thinking we've got on the agenda today a joint forward plan which describes how we're going to deliver our strategy for the next 5 years, built from places, built from communities, local demographics and the JSNA. Our next bit is about how we translate that into a really meaningful business planning cycle that's agile and responds and really delivers what people are telling us. And I think what you've described about the future modelling is something we perhaps need to build into that in a better way. There's great work that goes on with Sarah Smith and the team, local DPHs and their teams, but about how we work across our system in the operating model, designing this function and this planning cycle. So just a bit of an assurance on that. I think that's something that Ian and I can take away and think about.
That's great. Unfortunately, we don't have a public health representative here today, but thank you, Esther, for covering that. It's great. And I think we could explore how we take this into the partnership board. The next meeting's in September. That would be a year anniversary of looking at our response to the cost of living crisis as well. So I think it's a good time alongside the joint forward plan we'll talk about later. Thank you. James, to you, and Bev, I also wanted to come to you at some point before we finish, reflecting on the engagement session earlier today, if that's possible. Thank you. James.
Yeah, no, thanks, Chair, and thanks for the paper. And it's been a really interesting and great conversation, really. And I think a couple of elements I just wanted to pick up on. One, I don't think has been mentioned too much, but I'll come to it in a minute. But I think just going back to the conversation with patients and with the public and with people, I think is really key to this in order to be able to give that confidence, because I think there's a lot of this is about confidence and how we deliver our services there. So getting people on board is vital from not from just from the start, but as we develop there. And I think that is about making these roles, and probably wrong terminology, kind of how do we make them really look kind of sexy and really impactful there, because we're not always seeing that. We see that on a one-to-one basis when we have that care, when we have that in our home, when we see that, we see that. But kind of across the public and across, how do we make sure that it's seen that way? And I think that question about what the ICB can do then, and just this is moving this on a bit there, is about, well, actually, we actually have a role in that, because in that, how do we make sure that we're integrating with the community teams kind of research and development so that we can see that? So that then starts to bring on the universities, so they can then start to see the real benefit of what's going on in there. So people then come into the universities wanting to kind of work in the communities there. We then see that with innovations. We see that in our in our organisations at the moment, but then how do we really kind of emphasise that and integrate that across health and care? And then finally, the thing that we've touched on workforce an awful lot as a big enabler, absolutely the right thing to do. But I suppose the other thing is digital as well. And I think as an ICB, we have a role and we can support and we can, in terms of how we integrate digital across, ensuring not only we're getting the right funding, that we're putting that in the right areas there. It's across health and care, and we're seeing some of that happening in terms of getting health records in kind of care homes across our local authorities, so they can link in with our community teams there. So we can see that. So I think the ICB can do an awful lot here. It's not just about the sharing, and it's not about sharing across, but actually in terms of how we help support some of those research and development, the innovation across, and then our digital to help support that, not only to actually help with those services and with the integration, but actually make roles in there and can see that this is not wider than just the services, and actually starts to attract more and more people into this. So that's what I wanted to say. Thanks.
Thank you, James. We've got Sarah, Lucy, then Fatima. And then I'm going to stop taking questions. Then I just welcome some reflections from Bev, then Anthony and Rob. And Jonathan, as always, if you want to comment on the money before we finish up, that would be really welcome. So, Sarah, really welcome your thoughts on links with mental health.
Yeah, well, I suppose I was just going to come at it from a different angle in terms of the way we end up talking about community services, which I think is part of the perpetual problem. We go from defining what is actually highly skilled autonomous practitioners delivering care in the community now that years ago would have been in hospital. And then it quickly becomes very generic to all things to all people in terms of how do we address all of the determinants of ill health in communities. And that's not the job of all of our community services. Our health and wellbeing boards have a role to play in that in partnership with others. But to give credit to the people that work in community services is to be absolutely clear on the specialist skills that they provide, and therefore the resources they need and the investment they need to continue to grow and invest in those skills. If Steph Lawrence was here, who is the chief nurse in LCH, and all the work she's doing nationally to influence the growth of specialist nursing roles within the community because of how transformative that is. So I think it's a reflection back to us in terms of how clearly are we in our definition of what our community services offer is within the context of healthcare, and we need to hold on to that because that helps make those decisions. We don't talk generically about services in hospital settings, but we always do when it comes to community services. And not to say all the other work isn't important, but we just absolutely need to be fair and recognise what those teams do in, day out. And another reflection I've got, and it might be a bad example, and I'm certainly not going to say this is the way to do things. The biggest shift we saw in the model of mental health care was because of financial constraint, and that led to the closure of the asylums, both for people with serious mental illness or any other societal defined reason to put somebody in an institution. And that led to the advent of community services. Now, there's a whole lot written about how badly that was managed, but that was directly on the back of financial constraints, and we would never go back. And in fact, what we've seen since is growing more specialist community models of mental health care, whether it be eating disorder services, perinatal mental health, a whole range of other things. The challenge for us at the moment, and I won't be here for the private discussion, we are in significant financial constraints, but across the whole of the NHS, the pattern is sucking more and more resource back into our hospitals. The savings end up coming out of community provision because it is not well defined in terms of the clinical offer and recognising the impact that it has in terms of interventions and outcomes. So I just share that of listening to the way the conversation is going as to what we need to hold in mind in terms of the role of this board and the decisions we take, and where we will need to make perhaps some radical decisions to shift resources into where it's going to be needed in the future.
Thank you, Sarah. And I think it very much links with the collaborative commissioning for local delivery, the last recommendation, and Becky, your earlier point on addressing the inconsistencies, and Mel, your point at working at place as well. Sarah, thank you. And I know you're going to lead us in our Focus on session in September on mental health, which will link very well with this session. So we're going to go to Lucy and then Fatima.
Thank you. My point was really related back to the respect and visibility point, and I just scrolled through and looked at the performance report that this board oversees in terms of the performance of the system. And there is very little in there that tells me what's happening in community services. And I'm not advocating we have loads of KPIs, no. But there's something for me about actually the temperature check on the delivery of some of those acute performance measures are absolutely what's happening in community services, both the success and the risk and workload that are being faced. So 4-hour target, bed occupancy, elective waiting lists. A huge amount of that will be driven by that, and I don't see that in here. So I guess the challenge for me is what can we do to capture whether the benefits, the good work of community services is being reflected in our performance versus where there are risks and challenges where that's reflected. And my second point was around, again, the recognition piece. So we've kind of got a growing abundance of clinical networks within secondary care, but actually a huge amount of those need to be more integrated with our colleagues in community services. So we're doing that in neurology, I think dermatology but will be the next one, and just thinking about how can we do more of that, and how does that then challenge the mindset of some of our acute clinicians about what can be done in community, and also demonstrates, particularly in Harris's example, to medical students that there are a plethora of careers spanning inside hospital and outside.
Lucy, thank you. That's really practical. And our colleagues who've worked on the integrated performance dashboard, as you appreciate, and Theo, you talked about this at the beginning, we've talked about this as a board since April last year, there are certain metrics that we are have targets for. They are NHS England targets, which we are reporting on, and we're required to have oversight of that, as well as then defining what we want to measure as well. And I think it's something the Community Provider Collaborative have been looking into. You talked earlier about this, Rob. I joined you for your development session recently, and it's Thea's earlier point about defining not out of hospital but beyond that as well. Okay, we are get Fatima to you, and then Rob and Thea, if you want to share any reflections, and then I'll just come to some ICB exec colleagues as well to finish up. So Fatima.
Thanks, Chair. Apologies for taking another bite of the cherry, but it was just because I was really keen to make sure that despite this fantastic conversation, we nail some actions.
Yeah.
And sort of Cathy challenged us in the engagement session previously to try and take the power of this room to take some decisions. So I'm going to throw the gauntlet at the board. The first one is, and I think, Sarah, you nailed it, is the street cred of community services, and Mel's point about its perception by the public of what they're getting. Are they getting an Audi or are they getting a Golf? And I think for me, there is something about how we use the incredible finesse of our comms team that have done many campaigns in general practice within the Neighbours Root Out Racism to really heighten the profile of community services, being clear about what it is, but the value it adds, so we can really change the perception of the public when it comes to its relationship with community services. And if we can do something and agree that today, that would be fantastic. The second point is we talked about personalisation twice today. We referred to the Fuller report as well, which is in there. It's also in the NHS Assembly report. But we're in a position right now where NHS England have cut the funding. There is no personalisation funding. And if we're truly going to embed personalisation, then we need to resource the expertise to make it happen. So I'm asking the board to sort of stand by its rhetoric and see if they can put some commitment to resourcing the rhetoric when it comes to personalisation in community services.
Thank you very much. Thea and Rob, do you want to respond at all?
Just very briefly, so thank you for that challenge, Fatima. I think it's a helpful one. I think just coming to Lucy's point around the indicators, I think as much as it's not going to fix it for us, I think there is an element of kind of, again, representation of those and understanding of what's happening in a simpler way. I think there is a challenge to us as a collaborative to be made around how we get those 5 or 6 key things that we can use just to give people a kind of a feel of how we're doing, basically. And then there was another point I was just going to make briefly. Go on, Thea, I'll bring it up. Is there anything you want to say?
I was going to say I very welcome what Sarah said, which is you've got to hold on. You've got a huge range of very, very skilled professionals, such as very skilled extended scope podiatrists, extended scope physios, who are little understood. They're actually incredibly well respected by the public. So I think there is something to do around comms. But actually, the public, the health visitors, school nurses. These are really respected professionals that are loved by the public, but are sidelined often by actually national policy and little understood and little seen. I think the points you make, Lucy, as well were really well made, and I'm sure you and Becca are working closely together. So clinical networks, bringing people together to understand. We know that that's where real change happens. Real change happens in real work. And it's when you've got your diabetologist in the hospital actually saying, do you know what, I should be based in the community the whole time. Why am I doing any of my clinics here? Those are the shifts that happen, and they just happen with real people doing real work in real time.
Thank you so much, Rob and Thea. It's really grateful to you for your responses and preparation, and to others here today and behind the scenes. I want to just invite some of my ICB exec colleagues and Rob towards the end. Bev, there was something very practical, going back to that point that Fatima made in my challenge earlier about what decisions could be made today. We had a really good example of urgent care. Just wondered what your thoughts on that and any recommendations you might have for the board today.
Yeah, thanks, Chair. So just for people that weren't at that meeting this morning, we had 4 patient stories that were all incredibly powerful. And I think it's always best to start and to finish with patients, because that's what we're here for, patients and the public, my language. I think the 3 out of the 4 were absolutely superb examples of services working together and being really patient-centred. 1 not so, but we've got to, balance it so that we, whilst we give ourselves a pat on the back for, some of the care that we deliver, that actually we recognise that there's always possibly improvements that we can be made. And the one thing that we did focus on was a fall at home. And previously I've worked in provider organisations for decades, and we've found possibly usually frail elderly patients that have been long lives at home, or they've fallen and they've been conveyed to hospital. There was a fantastic example from the team that set up and delivered the service around a patient who fell at home, and the services that were wrapped around him and avoided an admission to hospital, a conveyance to hospital and an admission to hospital, and potential deconditioning, which we know happens all too frequently. And it was a fantastic example, and I think that my comment to you, Cathy, on that table, and I'm going to note to self, stop talking to Cathy whilst we're having development sessions, is that we need to look at this, across West Yorkshire and try to increase it, because I also chair the Yorkshire Ambulance Service Quality Oversight Group for West Yorkshire, South Yorkshire and for Humber and North Yorkshire, and one of the high incidences of patient harm is a result of failure of pathways. Now, it's not just about the false pathway, it's a number of different pathways, but that is a pathway that does come up very often, and we know that we've got increasing frail elderly patients. And I think the other thing that the kind of one of the closing comments around that patient story was around patient satisfaction and the really high levels of satisfaction reported to this. So it avoids added complexities by admission, it avoids conveyance to hospital, it avoids long waits in ED, and it's got increased patient satisfaction. So actually, for me, that's one of the things that the board needs to focus on. And already myself and Rachel's had a conversation. We don't let the grass grow under our feet, and we're going to have and we're going to look at what actions that we can take, both from a Yorkshire Ambulance Service perspective, and myself as both Director of Nursing of this board, but also as Chair of the Quality Oversight Group for YAS, and we're going to get that on the agenda even more so, aren't we?
Great.
Thanks.
Thank you. That is absolutely in action, matter of hours. Thank you so much, Bev. That's really, really helpful. And for colleagues who might be watching online and wanting to know more, that was a good example of where Yorkshire Ambulance Service was working with Calder and Huddersfield Trust on Falls and supporting people in their home to avoid hospital admissions. So, Anthony, if you cast your mind back maybe about half an hour ago, there was a challenge to NHS England. You're part of our team here, but I know that you have a foot in the camp with NHS England. I don't know what your thoughts are on how we are brought into acute targets, but also the importance of community services.
Yes, thanks, Cathy, and a very fair challenge, I think, from Becky earlier, as you say. I think it is fair to say that historically, in terms of national policy, community services haven't had the highest profile or the greatest focus in NHS England. I think that's indisputable. I think it is changing. I think we are seeing clearer national leadership, stronger national leadership around this agenda now. And I think we've touched a number of times on the value, I think, of where we see very specific national priorities on things like urgent community response and virtual wards and other things like community diagnostic centres, for example. So where those things are clear national priorities that come with funding or metrics associated with them, that creates a real opportunity for change that I think we are demonstrating. So I think we've got an opportunity as a system, particularly with our rapidly developing provide a collaborative for community services to continue to lobby and demonstrate the value of where there is a focus on community services. It makes a real difference to people. So I think we have to accept that challenge and gauntlet collectively as a system. And I think there also is some truth in the old adage of, you know, what matters is what gets measured. And so to pick up Lucy's challenge on the integrated performance dashboard, we can certainly look at whether, including metrics on UCR, virtual wards, some of the other things that we've touched on, that's an easy fix, isn't it? We can build into that and see what's possible. So we'll take that away as an action as well.
Brilliant. Thank you so much. I'm just going to do a bit of a summary on my scribbly notes and then hand... Oh, Jonathan, talk about money, please, and then Rob, we come to you at the end. Thank you.
If that's okay, just briefly, and I think it sort of builds on Anthony's point in a way, and it is a bit about what gets managed. So if I cast my mind back probably about 4 or 5 years prior to COVID, the system leaders at the time had a really clear commitment to differential investment into both mental health services but also into primary community services. So it wasn't about taking money out of acute trusts, out of hospitals, but it says of the money that we get, we want to invest more proportionately into those services because we think it's important. And to an extent that was followed up by a piece of national policy that came out just before COVID, but it was then lost. It got lost. And if I think about the last few years, and it's a difficult picture to get some really clear messages on, not least because of Mel's point, the fact that there has quite a lot of blurring of boundaries. You know, the money that goes into BHD isn't just acute services, is it? But, you know, if I think about the big chunks of money that have come out in the last few years, clearly elective recovery funding is billions to address the waiting list. As Thea's pointed out, that's the hospital waiting list, not the community waiting list. There have been streams of money for things like virtual ward, ageing well, etc., which has been welcomed. But there is something for me, and I'm sure AC may have said this had he been around the board table, as Becky said it today, that the Finance Investment Performance Committee, I think, could do with having a look at what the differential spend is now across the ICB from the NHS, recognising it won't be perfect, but we can get some broad brush responses to that, looking at what does that look like across places, because I think that's important, and to see, well, what have the trends be? I've got a view of what it'll look like, and I don't think it'll chime particularly well with the conversation we've had today. But I think we probably need to do the work.
Okay. As you've all been talking, I wonder, Thea and Rob, maybe taking on board the comments today, maybe if you are very welcome to refresh any recommendations if you want to, but I'd like to invite taking this paper or a version you might want to refresh for each place committee and particularly the Finance Performance and Investment Committee and the Transformation Committee to take for discussion as well. I know that's happened by place committees before in taking the paper that we've had on a focus on session in deep dive. Rob, do you want to come in now? And I can do a bit of a summary in a moment, but thank you for the discussion.
So I'll preface my remarks by reflecting on, I do have in my interest register, it does reflect that I'm an honorary fellow of the Queen's Nursing Institute because of my advocacy for these services, which I'm incredibly passionate about, because I've seen, like others around the table, what they deliver for people every single day. And we need to ensure that we have the right support for them. What I would suggest, if you're okay, Cathy, I mean, you don't have to agree with this, but I think it would be worth us. I'll make some remarks, and I think we should go through the 10 recommendations, and we could see what the action is that we want to take against each of them, which we can agree now, because I think there are some actions that we could agree now. But before that, I mean, I think there are a couple of things that I'd reflect on. That I thought Sarah's intervention was really, really important. You know, autonomous professionals who are specialists in communities delivering services based on risk. And the degree of risk that people carry is substantial. And that means that we need to support people to be able to do their job well. I also think that when we think about community services, Sarah and her colleagues run community services. Most services in mental health are community-based services. They also have hospitals, but it's mostly community services, and we mustn't lose sight of that. I'm also struck by the fact that we have a West Yorkshire Association of Acute Trusts, which has 6 members. 4 of those members are integrated trusts who deliver community services. So what's their leadership role of those acute trusts, as they call themselves, in promoting advocating for investing in community services and pathways. I think that the discussion we had in the pre-meeting and this discussion today reinforced that this is core business for us. Clues in the title, isn't it? Integrated care system, integrated care board, looking at integrated care, most care delivered in the community where people need it to be joined up and integrated. So we should see this as core business. In doing that, the paper doesn't address the opportunities, I think, in the operating model going forward. And we've touched on that a little bit today. So talking about places, I think Rob started his conversation with, well, places is where most of this happens, and Mel reinforced that in a really helpful comment earlier. But the operating model that we'll talk about later in the board meeting about where decisions get taken, who's in the room, how do they get delivered. It seems to me community services providers delivering integrated care in systems have a big opportunity to drive change and remove some of the barriers to change, and we should take that opportunity. The issues on money that Jonathan reminded us of, we do need to keep in mind. So when Lucy Cole and I were the only two members of the Sustainability and Transformation Partnership back in 2016, and we produced our first strategy, we did talk about differential investments in community services. And as Jonathan said, the money that's been made available to the system during COVID has dumped a lot of money into the system in a way which we need to unpick. So we've got the opportunity to do that, and we should take it. And I should remind the board that our elective recovery fund is slightly different from the national arrangements because we want to keep the opportunities that we had, which were to remove the incentive around activity in hospitals back into the incentives around pathways and outcomes. The balanced scorecard points, I think, are really well made. There is a good piece of work done by our region on what they call, and I, like others around the table, resist using this terminology, the out-of-hospital balanced scorecard. But there are a set of metrics that are being developed at regional level which cover some of the territory which we could look at. I know we've got concerns about the data quality, timeliness, etc. But I think as a minimum we should be having things like 2-hour urgent care response standards. Are we meeting them? Virtual ward numbers, what does it look like, etc. Just so it gets into the ether, even if it's not the whole picture. I'd remind colleagues that local authorities commission a substantial amount of community services, and their budgets are under substantial pressure, and they affect some of the people who are most vulnerable, including children. So we do need to make sure that that recommendation in the paper, which we'll come to later about place-based commissioning, recognises that. The Fuller report's been mentioned several times. I wanted to remind people that the Fuller report talks about a set of things that we have to have an urgent response to people who need it. We have to have an ongoing managed response for people who need continuing ongoing support and care. That should be personalised. We need to have a focus on prevention. And we just resort to the full report being about integrated multidisciplinary teams. It's not. It's about those 3 sets of services for a population. And it also says, therefore, that we need to focus on the workforce, IT, and capital. And our capital strategy does not address the needs of community services and primary care sufficiently. So again, we've got a Fuller board that we could put some of this stuff into, but if we think Fuller's just about integrated multidisciplinary teams, it's not. And some of those things need to be done at West Yorkshire, and some of the things need to be done locally. And we'll come later on in the conversation to what we're being asked to do around planning for winter and our self-assessment against that, including improvement support. But some of that plays into this agenda too. So I just wanted to make those comments before we go into, I think we should go against each of the 10 recommendations. Do we accept them? And then what specific actions have we agreed today which might help? And I've got some proposals on what they might be, but I think we should do that if that's okay.
Yeah, of course. I think that's great. Okay, thank you, Rob. As ever, I think it's really helpful to have your reflections at the end. So, first of all, as a board, we have got 10 recommendations in front of us. I haven't sensed any dissenting voices, but as Rob suggests, we can go by one, particularly to get the actions there. But my sense is that we're all in full agreement and support them in principle. The first one is around the policy context and the breadth of community services and being considered an equal partner. So we talked about culture, we talked about organisational development. Rob, are there any thoughts on anyone else around the table on specific actions here?
Well, I think we've got a really strong set of voices through our providers into things like the Community Services Collaborative nationally, and we've got individuals like Steph Lawrence who are playing into the influencing agenda. But you and I, through our work with NHS Confed and others should continue to advocate for this work. Yeah. I think over and above that, I don't think we're being asked to do anything else from what Thea and Rob have suggested.
Thank you. And as we know, we have Karen Jackson of Locala, who is our community services representative, who is, I'm sure, is partly gutted not being here today, but I'm sure very happy being on holiday as well, which reached well deserved. Endorsement 2 is around the ambition in West Yorkshire to keep people well and closer to home. That left shift about care outside of hospitals. So we've talked about the metrics. They're not quite the wording that we want. Rob A, you talked earlier about 5 or 6 key metrics to demonstrate benefits. Is that an area we could look at, or is there anything else that you'd want to note down?
I think we should be asking place leads and maybe place chairs to ensure that the local plans that are signed off in places deliver that strategy.
Yeah. Becky?
Is this where we do something about committing to understand need?
Yes. And I think there's something earlier about definition as well that links with the earlier point. Okay. So, again, fortunately, we don't have a public health colleague with us, but I can work further, and that links back with places. Recommendation 3 is about the financial position and the support and development. So, Jonathan, you talked earlier about that review, looking at the differential investments, the Finance Performance and Invest Committee. I invite place committees to look at that as well. Is there anything else to add there? I don't know.
So I was going to suggest that we've got so ask Jonathan and the team as part of the long-term financial model over the next 5 years to say where we're investing, which allows us to deliver efficient and effective services. And that's allocative as well as technical efficiency, and some of that will be about investing upstream in prevention and joined-up care in communities. So when we receive that long-term financial model, I think we should ask, as a board, do we want to set a standard of community service investment? And does this do that? And is it backed by the evidence of where the best investment should be made? Seems to me to be a reasonable thing for us to do in a constrained environment.
Okay, thank you. And in talking with Thea and Rob yesterday and preparing for today, there's something around that systemic strategic investment, which I know is the ambition, and looking at new money as well as existing money. Okay. Recommendation 4 around workforce challenges and commit to community-based staff being a priority. Kate talked earlier about elements of the workforce plan, community staffing being priority, and the placements as well, making the career attractive and understandable. Dan, do you want to come in there? Sure.
I'll start again. I think what Rob was saying is really important, and I wonder if there is evidence out there that either this board can collect or perhaps the community collaborative can start to look at, of where other systems are moving money around appropriately between services. If it works somewhere else, is that something that we should be putting as a benchmark? Because I don't know right now, and if it's working elsewhere, it would seem like we should perhaps learn from it. So I think that's perhaps partly down to the collaborative to do, but it would be really helpful to get the ICB's support in that as well.
Great. Thank you, Diane. Rob?
I wondered, so one of the things that we've done in the past, and, I don't want to put Thea under any pressure before she started her new job, but we did work with Nigel Edwards at the Nuffield Trust to say give us the evidence base for investments in and what the efficacy for community services looks like in systems, and he did a report for us. So we could choose to work with think tanks, national or local, to help us as we develop our strategy, our financial strategy into the future and the investments. We've also got the benchmarking club that community providers are part of, which again provides us with some substantial insight into what works.
Okay, thank you. And Thea, you talked earlier about other European examples, as well as we want to learn and exchange practice with our fellow northern systems as well. So that'd be welcomed. Okay, nods around the table. Recommendation 5 round is workforce. Sorry, I thought we'd covered it. Have we got anything further to add on workforce around challenges? Kate?
Sorry, not so much a challenge, but I think just to reiterate, certainly the ask is about this being a priority. I don't sense anybody saying no, and I think there's some practical first steps. And I mentioned earlier that the work we're doing with Becca around identifying some of the priority under what I'm calling a needs analysis. I think there's something also around a look at the people board agenda, and also making sure in the new strategic retention group that we're setting up that this is one of the priority agendas. So I think there's a commitment from me for those things, but some practical steps to take that forward to start with.
Great. Thank you, Kate. That's really welcomed. Number 5 is around the growth, noting the growth in demand for services, and there was an earlier point around recognising the waiting lists as well, and the indication for long-term resource and new models of care. I wonder if that links back with recommendation 2 and 3 as well. I don't think, is there anything else to add?
Yeah, we talked about doing some future modelling for the strategy.
Thank you very much, and that comes back to the point on population health and fully understanding the needs of communities.
Not to extend that too much, but I do think that there's a real opportunity for us in our role to work with our public health colleagues on understanding the consequences of the pandemic, on the long-term health needs of people, plus, whether that's through delayed treatments or the direct consequences of COVID on their mental and physical health, and doing something which allows us to do some better work in the long-term financial model and the service models for the future. So I do think it's a really good, and linking to Becky's points earlier about need as well as demand.
I think, Rob, just to say that what we're seeing, and Sarah, you'll know this too, that what we thought was going to be a spike in children's mental health is not a spike, it's consistently stacking now. So we can't treat it, something's going to go away, it's now here. So it'd be good to now treat it as here.
Thank you very much, and we won't lose those points earlier around poverty and responding to the cost of living crisis as well. Thank you. Recommendation 6, driving forward the transformation, where providers have collective desire to make change, and this also linked around self-care and new models of care and public communications. Is there anything to add there?
That feels a bit too, if I was going to be challenging for a minute, that feels like if providers want to, then they might get around to it. I know that's not what it says, but if you wanted to be challenging, actually we should be challenging each other through that mutual accountability model, I think, to say, look, where there is a need for change, we should be driving change together. And what we're seeing in other places is that where providers work together on that, and as we, again, it comes back to my operating model point, as we transition more capacity from commissioners into supporting providers to do that work, there's more opportunity, I think, to do it.
Thank you. Recommendation 7 around the establishment of the provider collaborative and endorsing that shared purpose. And I think there's something you talked about earlier, Rob, around the roles of integrated trusts in that, as well as the breadth and depth of multidisciplinary and multi-agency teams. So we're supportive of that and hearing their voice through this board, particularly on the partnership board as well. Rob, is there anything you want to add?
Just to kind of maybe respond to Rob's, wasn't a challenge, Rob, was it? Maybe it was, I don't know. I think there's the niceness of, so we've got Wyatt, and the reason the Wyatt is structured as it is, I think, is because everyone's going into that room with predominantly a kind of an acute hat on. I think it goes into other areas. I think the strength of the community collaborative is the difference in provider in that room. So CHFT, I think, brings something nice to it, because some of the barriers we might be talking about, they're less than they were, but between organisations, we can work that through in our organisation and kind of help with some learning around that. So if that case is there in CHFT, we make that transition within the organisation. Half the challenge usually is making that case to yourself and evidencing it, and sometimes taking a leap of faith. So I think it's probably, just to respond to Rod's point, I think the way we structured it is right, and I think both kind of have strengths in terms of the difference of provider in the room.
Thank you, which then comes on to recommendation 8 around the shared voice of that provider collaborative as well. And I think it's something, Dan, you and I talked about a good 18 months ago. This is our newest provider collaborative. So there's also supporting the learning and the infrastructure from a collaborative like YAP, for example, around acute services on how it's worked, where the life stage that they're at as well, alongside the mental health, learning disability and autism collaborative, as well as the one we have for hospices. So I hope you feel even coming today, we're trying to aim to fulfil that recommendation 8 as well. Recommendation 9 around that collaborative commissioning for local delivery. So there's inconsistencies there. We've talked about how we can look at that at Transformation Committee, as well as looking at the Finance Committee as well, and encouraging places to do the same. Is there anything else to add? We've really got a passion there for tackling the inconsistencies and the variations. Thea?
It's a huge point, but it is something that Rob mentioned before. Of course, a range of our core services are commissioned by local authorities, and there needs to be some space of recognising the huge pressure local authorities are under and the impact that has on these very crucial services locally, with massive differential, therefore, across West Yorkshire. So it's not just health commissioning, and that is quite a complicated area to be in.
Okay, which comes back to the discussion across places and local government as well. And there was a point also that came out in our engagement session earlier today about removing commissioning boundaries in places, so enabling the support for the person, not based on commissioning history as well, which I think was a really key point that one of our colleagues made. And our last point...
Yes, sorry, on
yeah,
that.
Majid.
8.9 it's important to just build on what Kim mentioned earlier on about the role of community and voluntary organisations in that commissioning framework, where the communities are where services are delivered by, with, and in communities, by community groups also.
Thank you. And then that links back to what Kim led us on back in March, which is around the sustainability for the sector as well, and that longer term view as well. Thanks, Majid. And number 10, around the supporting the collaborative as an enabler and facilitator of relationships and networks. So I think I've sat in the room with the collaborative, and it was very interesting. The people were asking, am I included here? Am I a member? And it's like, of course, this is an open place, a very broad umbrella there. Rob?
I was just going to suggest that as part of that, we're grateful to the collaborative for the input into the operating model considerations, and we should use the work we're doing on the operating model to try and amplify number 10 as much as we can.
Thank you. And just from my notes from earlier, also that connectivity that we need to explore with research and development and the digital agenda and our digital strategy across West Yorkshire, and making sure that clinical networks are coming together as well. Okay, colleagues, thank you so much. We've spent over an hour on this today, but it feels incredibly important at this time for us as an organisation, it's this time for our services and our partnerships. So, and Thea, particularly, we get to have some time with you as well before you move on to the Nuffield Trust as well. So congratulations on your role. We wish you every success. But I think Rob's trying to already encourage you to stay in touch and work with us as well. So thank you.
I have every intention of staying in touch.
Good. So Rob, Thea, Diane, Becca, many other colleagues as well, including Rachel from Yorkshire Ambulance Service, thank you for your time today. We're going to finish now this section of the board meeting and take a break. Thanks for anyone who's been watching live online or on record as well. We hope you found this a really helpful discussion today on the importance of community services and care closer to home. So we'll take a break now. Thank you.